Why does health insurance feel so broken? Here's this week's healthcare deep dive. So, the health insurance market is not broken in any one place. It's pressurized all over the place. This is not a Democrat or Republican rant. This is not partisan stuff. This is a math problem. And math does not care who you voted for. All right. Healthcare spending is now 18% of the GDP. In 2000, it was about 13%. And by 2033, they predict it to be as much as 20% of the GDP. Guys, that means that one in every $5 we spend in America will be healthcare related by that time. Okay. This is not just a benefits problem. This is an economic problem. For employers, it's ugly renewals. For employees, it's higher per paycheck deductions. For hospitals, it's negotiating fights that you see pop up in the news all the time. For politicians, it's just simply talking points. And for everyone else, it shows up as a mild urge to scream at a pillow. All right. At some point, your health plan stops acting less like an employee benefit than it does just a rude roommate who takes up too much space and eats all your leftovers. All right, so let's get into it. Number one, healthcare is eating more of the economy. Average family premium in 2015 was about $17,000. Today, it's $27,000. Employers are paying roughly 75% of that, employees paying 25% of that. But since in the last 10 years, employer contributions have gone up nearly 60%, and the employees' portion has gone up nearly 40%. And many carriers are now building into their prices 10 to 12% medical trend. Okay, so trend is a very important thing. When you hear trend, this is just the baseline in which rates are going up. They start with trend and then they build other things on top of that, the taxes, the fees, the underwriting, the claims, the pooling, whatever it may be, they build on top of that. So when you hear medical trend is 8%, that doesn't mean your renewal is 8%. That means it's starting at 8% and going up from there. So renewals are just basically lasagna. There's a lot of different layers that go into it. Unfortunately, every layer costs more money. All right, number two, small employers are running out of easy buttons. So small and mid-sized employers have it really especially tough. The fully insured small group rates are coming out anywhere between 11 to 20 some odd percent renewals here in 2026. Individual ACA marketplace premiums jumped 26% in 2026. And smaller employers don't have the advantage larger ones do, whereas large employers can see their claims data. They understand what's driving prices and they can pull different levers. Small employers, generally speaking, don't see any of their claims data. They just have to get the renewal. And when it comes in and it's very high, all they can really do is reduce the benefits, shift more cost to the employees, change the carrier, reduce the network, whatever it may be. Or you can look at alternative strategies like ICRAs or PEOs or level funded or joining a self-insured captive. Lots of different options there that small employers do have potentially, but none of them are magic. Nothing, but doing nothing is also frankly a strategy. It's just a really expensive one. But in the fully insured group market, employers are often driving through the fog and just simply being told, even though they can't see out their front windshield, make better decisions. Third, pharmacy is where simple questions go to die. Prescription drugs are one of the biggest accelerators in health plan costs right now. Drug spend is driving some of the highest estimated increases. Just 11% of your increase is just the prescription drugs. Specialty drugs are a big problem. They account for 2% of the drugs prescribed in America, yet account for 50% of the total drug spend. Commercial pharmacy spend per enrollee went from about $690 in 2014 to almost $1,700 in 2024. Prescription volume rose 28%, and the average prescription cost rose 84% in that amount of time. Crazy. And pharmacy now represents 27% of the employer healthcare spend. All right. That was just 21% 2 years ago. That's how fast it's increasing. This is not just, hey, drug prices went up. That is a specialty drug. It is biologics, it's infusions, it's GLP-1s, it's rebates, spread pricing, PBM-owned pharmacies, site of care, all kinds of stuff where the system is built so that neither the employer nor the employee can even ever see the real receipt. Trying to understand a pharmacy pricing is like going to a restaurant and seeing the steak is $900, but if you got the right code, you can get it for $42. But that's only if you order from the right waiter. There's just so many gotchas in the whole system, and at the end result, all of us just pay a lot more. Third, let's go a little deeper into prescription drugs. GLP-1s are both a miracle and a math problem. So the GLP-1s is a perfect example of the healthcare market dilemma. They may be clinically helpful. They may reduce long-term chronic diseases. They may improve lives, but that's all in the future. Employers are paying premiums now, not 10 years from now. So some employers are adding 2% to their budget just simply to cover the additional cost of these GLP-1s. All right. The possible savings, like we all can see, will show up later, but is that going to be for another employer? Is that going to be for Medicare? Is it going to be for Medicaid? It doesn't impact the employer today other than negatively, frankly, with the dollar spent. So our system is built around 12-month renewals, not 10-year health outcomes. GLPs may be good medicine, but they are a brutal benefits math problem. Five, I'm talking to you employers. The employer sponsored plans are becoming the pressure valve. All right. Then there's a payer mix problem here. And by payer, I mean employer sponsored plans, Medicare, Medicaid, TRICARE, all these are different payers. All right. Hospitals and providers treat patients under Medicare, under Medicaid, under these different under ACA. All of those have different reimbursement levels. Medicaid is free and almost free because they reimburse very low amounts. That's why you don't see a lot of doctors in those Medicaid networks. Medicare is a huge population of people, but that reimbursement is very low too. The one big beautiful bill that just passed that squoze Medicaid and Medicare, all of those squeezings pop out in the commercial plan. So think about it like a balloon. You can squeeze a balloon here, but it's going to pop out somewhere else. Our commercial plans are the pop out. That is where all those extra costs go to all the hospitals go to make up those costs. So for instance, Medicare might bill 75 cents on the dollar what the hospital needs to cover that cost. But the hospital is charging commercial health plans in California as much as 250, 260% more than Medicare is billing. So this is the balloon, and we are the balloon on the other side of that. This means employers are not just paying for their own healthcare, they're paying for the whole healthcare system. They're also absorbing pressure from the rest of the system. Five, enough of bad news, Billy. I got some good news. The flashlights are finally coming out. And this is where we can have a little bit of hope. For once, some of the attention is moving in the right directions. PBMs, we've talked a lot about them here, are under serious scrutiny. New transparency rules are pushing for more disclosure on rebates, spread pricing, the net cost versus the gross cost, the PB-owned retail, mail order, and specialty pharmacies. The FTC has also taken action aimed at moving drug prices away from high list price with rebate games, so they charge more and they're rebating somebody or some bodies in that, down to what the true net cost pricing is. There's also some bipartisan energy here too. Senators Elizabeth Warren and Josh Hawley, one very hardcore Democrat, one very hardcore Republican, have both pushed bills aimed at PBM conflicts of interest in the healthcare consolidation. Now, that's not exactly the political buddy rom-com you were looking for this summer, but when Warren and Hawley are on the same page and pointing at the same smoke, you know there's fire. Okay. So we're also seeing more pressure in the direct-to-consumer drug pricing, most favored nation pricing ideas, Medicare drug negotiations, and employer fiduciary responsibility. So we can get a little more clarity on, especially on the prescription drug pricing. So will any of these fix healthcare overnight? Absolutely not. It's not an overnight fix. We're chipping away at the problem. This is healthcare. We don't do overnight in healthcare. We do 17 committees in a PDF. All right. So, but more transparency is good, no doubt about it. More competition is good. More pressure on hidden compensation is good. More scrutiny on consolidation is fantastic. Enforcing everyone in the supply chain to explain their math is fantastic. So the broker's role is changing. The old broker model was simple. It was get the renewal, spreadsheet the renewal, put it in front of everybody. Here's the more rate. Pick the best bad idea out there, and then just repeat it next year. That model is not enough anymore. Employers now need to ask better questions. Where's our money going? What's driving this pharmacy spend? Are rebates being passed through? Are we using the right network? Are we steering care away from other areas and saving some money? Are we educating employees? So for those of you with smaller employers, smaller groups of employees, you don't have some of these levers. Education of employees is critical. Are we building a multi-year strategy? What is this? Is this just a 12-month deal and we'll see you next year with more bad news? Basically, if your entire renewal strategy is, well, let's just see what Blue Shield has to say. Congratulations. You have a weather report, not a strategy. Based on closing, where are we really? Healthcare is consuming more of the economy. Premiums keep rising. Pharmacy is becoming a bigger piece of the pie. Hospitals are fighting for higher reimbursement levels. Government payer pressures are spilling into commercial plans. PBMs under the microscope, and small employers are running out of easy buttons. But the curtain is starting to come back, everybody. PBMs, carriers, hospitals, TPAs, drug companies, brokers, Everybody is going to have to start explaining their math. And honestly, this may be the healthiest thing that's happened to this business in years. Healthcare is the only place where everyone says they are lowering the price, but somehow the invoice keeps getting heavier. All right. At some point, we should stop grading intentions and start following the money. That's your deep dive. See you next time.